Hi, everyone, and welcome to today's webinar, Navigating Food Allergies and Intolerances, Charting a Course for Healthcare Food Service Teams. My name is Jenny Kinter, and I am an Associate Marketing Manager at General Mills, and will be your host for the webinar today. This webinar is sponsored by General Mills Food Service, providing the food people love away from home. We are proud to offer the quality products food service professionals rely on for consistent results in their own operations, as well as the beloved brands their customers know and trust. Today's webinar is supported by General Mills Bell Institute of Health and Nutrition. The Bell Institute is the company's internal source for scientific health and nutrition expertise. Before we begin today's program, I'd like to share some reminders. Today's webinar will be recorded with a Q&A session at the end. However, you may submit questions at any time during the webinar by clicking the Q&A icon in the upper right-hand corner of your screen. After the webinar concludes, you will receive an email with links to the slides and continuing education credit certificates in the coming days. With that, it is my absolute pleasure to introduce today's presenter. Margaret Maggie Roche is the founder of Roche Dietitians and a nationally recognized leader in nutrition consulting. Maggie's mission is to educate and empower those who nourish others. She believes that food is medicine, and she uses evidence-based standards to promote health and wellness through nutrition, especially for the older adult. She guides organizations and individuals through the complexities of medical nutrition therapy and the business of serving food in healthcare. Maggie is a registered dietitian with a master's degree in clinical nutrition. She has advanced credentials as a board-certified specialist in gerontological nutrition and is distinguished as a fellow of the Academy of Nutrition and Dietetics. For more information on Maggie, please visit rochedietitians.com. Thank you so much for joining us today, Maggie. With that, let's begin our presentation. I hope you all enjoy.
Thanks, Jenny. And thanks to the Bell Institute for inviting me to present this information about food allergies. And I also appreciate that so many of you have taken time out of your busy days to log into this webinar. So let's get started with our learning objectives. Our first objective for the learner is to be able to identify key features and characteristics of food allergies, intolerances, and celiac disease. Also, the learner will be able to distinguish between a food allergy, food intolerance, and celiac disease. And lastly, the learner will be able to describe common approaches and best practices to managing food allergies and intolerances in healthcare food service. But before we get too far, I thought it would be a good idea for us to get to know a little bit about each other. So we've got a poll. We only have 2 polls today, and James is going to launch the first poll, and Jenny will talk us through it.
Thank you so much. All right, your poll should have just launched. And your options are hospital, long-term care, assisted living, independent living, industry, or other. The question being, in which setting do you work? Go ahead and input your responses. All right, Maggie, we're getting a couple more coming in right now. It looks like 46% are hospital, 19% long-term care, 24% other, and then assorted responses for the rest of the folks. So hospital in the lead by a large margin.
That's very helpful because that'll help us with our conversation in terms of how we tailor some of our examples. All right, let's get started then with some statistics about food allergies. Now, these statistics came from FAIR Food Allergy Research and Education, and their mission is to improve the quality of life and health of those with food allergies through transformative research, education, and advocacy. And they're very well known for their website, and they've got a lot of great consumer level education for folks who are dealing with food allergies. So according to FAIR, 85 million Americans are living with life-threatening food allergies and intolerances. There has been a 377% increase in the treatment of diagnosed anaphylactic reactions to food between 2007 and 2016. Every 3 minutes, a food allergy reaction sends someone to the emergency room. Now, the National Institute of Allergy and Infectious Disease is part of it's the allergy research component of the National Institute of Health. And they've got some statistics too. They say that 1 in 10 adults and 1 in 13 children has some type of food allergy. Right now, here's a resource that is hot off the press. It was just published this month by the Academy of Nutrition and Dietetics, and it's the Health Professional's Guide to Nutrition Management and Food Allergies. And I thought what they said about the statistics is very interesting. They're citing that in the U.S., the prevalence for adults, the prevalence of self-reported food allergies increased from 9% in 2001 to 13% in 2010, but the prevalence of physician-diagnosed food allergies remained stable over the same period, 5.3 to 6.5%, somewhere in that range. And then a more recent 2019 survey reported that 19% of adults believed that they had at least one current food allergy, but only 10% had actually had a physician-diagnosed allergy. So what that means is that following these trends and statistics is very difficult to verify. The self-reported cases of immune-mediated adverse food reactions, meaning true food allergies, is grossly overestimated according to this new book that's out. They do note, though, that age makes a difference, that younger people tend to have a higher prevalence. But what's interesting to me is that still everyone agrees that we have a prevalence between 5 and 6.5%. So for those of us working in, let's say, a long-term care community that's got 100 beds, that means 5 or 6 people have a verifiable food allergy. Or if you have a 300-bed hospital, that's 15 to 20 people that you're serving food to who likely, statistically, would have a food allergy. So that's something that's interesting to keep in mind. Now, when we talk about food allergies, food intolerance, how are we going to categorize these? Well, one way to think about it is, we've got these adverse reactions to food. Now, they can be categorized either as toxic or non-toxic. By toxic, what we mean is that everybody who eats that food is going to get sick. Salmonella is a good example, or other types of food poisoning where if the toxic is there, if you have a human body, you are going to get sick from it. Where non-toxic is more individualized. Some people's immune system responds to food differently, or people respond maybe through some type of intolerance to food differently, depends on the individual. And I should point out that we talk about these in terms of kind of how we can define it, or what language we can use is that the food causes reproducible adverse health effects. All right, another way to look at this, adverse reactions to food, is, of course, between immune-mediated and non-immune-mediated, meaning how involved is our immune system. Now, there's IgE, and we're going to talk about that in a little bit more detail, but there's also non-IgE or mixed, meaning what components of the immune system respond to this triggering food. And so, as for example, there is something called eosinophilic esophagitis, which is an immune mediated response mainly to animal proteins. It manifests in the esophagus. And that is a actually it's mixed between IgE and non-IgE type allergen response. But what we're going to talk about today are the classic allergies, which is IgE. But just know that there's other types of allergies out there. And of course, celiac disease is considered immune mediated. The immune system is involved with celiac disease. Now, non-immune mediated includes toxic, that we just talked about, food poisoning and other types of toxicities. Enzymatic, think about lactose intolerance. That simply is the person does not have the lactase enzyme to break down the milk sugar lactose. And then there's others that are not even described. There's people who say, I don't tolerate cow's milk, or I don't tolerate wheat in general, where I get a rash, or I don't feel good, or I get bloated. These are kind of non-describable or maybe I should say non-identifiable right now, but there's certainly non-immune related responses, adverse reactions to food. We should talk about the terms intolerance. I've used it a few times. Other people use hypersensitivity. I just thought it was interesting that the National Institutes of Health are saying, we need to come up with better words besides intolerance and hypersensitivity. And perhaps as we learn a better way to understand what the mechanisms for these things are, we'll have a better way to describe them. But we'll probably you'll hear me using the word intolerance more as we go through the slides. So again, what is a food allergy? National Institute of Allergy and Infectious Disease says a food allergy is a reproducible immune-mediated reaction following the consumption of a particular food allergen. FAIR, as you can see, is an advocacy group. They get a little more personal about their definition. They say a food allergy is serious and potentially life-threatening medical condition affecting 32 million Americans. Food allergies, oops, hold on a second. Okay, yes, food allergies and other types of food hypersensitivities, there's that word, affect millions of Americans and their families. Food allergy may occur when a person eats, also touches or inhales a protein in food that elicits an immune response. Some people are allergic to more than one food. Food allergies may start in childhood or as an adult. Food allergies occur when the body's immune system reacts to certain proteins in food. That's, the immune system has to be part of it for it to be counted as technically as an allergy. And they vary in severity and at times unpredictably, from mild symptoms involving hives and lip swelling to severe life-threatening symptoms, often called anaphylaxis, that may involve fatal respiratory problems and shock. These are potentially life-threatening, and so that's why we always need to take food allergies and the people who live with them seriously. While promising prevention and therapeutic strategies are being developed, food allergies currently cannot be cured. So let's look at that classic food allergy. This is the classic IgE-mediated food allergy. When a person eats, touches, or inhales certain proteins from the offending allergen. Now, again, not all people will respond to, some people, it's just if they eat it, then they have problems. Other people, if they touch it, you also often hear the story of, the father who had cereal and milk and kisses his child goodbye in the morning, and the child gets hives on their mouth or their face from the father's food traces that were on his mouth. So it can be touching, it can be inhaling. That's why we have, we don't have peanuts on airplanes anymore because it could be, for some highly sensitive people, it could be an inhalation a trigger as well. So, all right, so the person inhales, eats, touches, or inhales certain proteins from the offending food allergen. The body's immune system then is triggered. The immune system produces an antibody called immunoglobulin E, IgE for short, and these IgE antibodies fight the enemy food by releasing histamine and other chemicals, and these chemicals often trigger the symptoms of the allergic reaction. IgE-mediated food allergies or immune-mediated food allergies are characterized by rapid onset of symptoms following the ingestion of that trigger food. So symptoms typically appear within 30 minutes, with nearly all reactions within 2 hours. And these are the areas that are typically affected: skin, GI, cardiovascular, respiratory, and others. And skin, it's that classic hives, itching, swelling, GI, vomiting, diarrhea, abdominal pain. Now we're getting a little more serious: hypotension, loss of consciousness, wheezing, coughing, sneezing, runny nose, congesting, swelling of the throat and vocal cords, difficulty breathing. This is when we're getting around, shock, anaphylaxis, and serious risk for death. And then some of these miscellaneous symptoms include dizziness or just a sense that something's not right, impending doom. So how do we test for this? Well, that's part of the complication of food intolerances and allergies. Testing to diagnose an IgE-mediated food allergy includes that classic skin prick test, And also there's a specific IgE blood test, which measures the level of IgE antibodies in response to that specific trigger food. But these tests show sensitivity to a potential food allergen. It may vary in the degree of the response, and they do not diagnose with 100% certainty. And so to really consider and to diagnose, the allergist has to look at these tests in the context of the reproducible symptoms from that trigger food. And I do want to make this point, which I think is really interesting. The amount of response, maybe like from that skin prick, if you get a big welt, it doesn't necessarily mean that then you're going to get a big allergic response in that person. So that's where the unpredictability comes in and the uncertainty, and that's what worries folks, is that they don't know how serious of a response that they're going to get. And so the treatment primarily is we have to avoid that food completely because of the unpredictability of it. There are some immunotherapies. They're doing a lot of work now, even with small amounts of the actual allergen being provided to the person in very controlled environments and other immunotherapies. But we've got a ways to go. So let's talk about this in the context of food intolerance and just to kind of show you how complicated this can be. A food allergy is, as we discussed, immune mediated. The immune system is part of it. Where an intolerance, the immune system is not part of the process, but they have very similar symptoms and overlapping symptoms. That's what complicates things. Now, of course, we do have the IgE testing either through the skin or the blood, and in food tolerance, there is no test. But on both of them, we rely heavily on a clinical history. When did you eat it? How soon did you get responses? What type of response did you get? Did you ever eat it again? What kind of response? Looking for that reproducible response. But again, you can have a reproducible adverse health effect from a food, and we may not necessarily have the immune system involved, which is why the testing is nice. It can at least point us in the direction that we're talking about the immune system. We're going to switch gears a little bit and talk about celiac disease. Again, celiac disease is an immune-mediated response, adverse reaction to food. What is celiac disease? It has to do with gluten, and gluten is an alcohol-soluble protein in cereals, wheat, barley, and rye in particular. It's commonly found in many foods, breads, pasta, baked goods. Those are the obvious. Soy sauce is a little less obvious, but everything, soup may have used a wheat-based thickener, candies, almost any food. And fortunately, there has been a lot more awareness about gluten in food, and there's been a lot more gluten-containing or gluten-free foods, I should say, available in the marketplace that makes it easier for people who do need to avoid gluten because of celiac disease. Now, celiac disease is, as we said, immune-mediated, and it has to do directly to the small intestine. It's a chronic condition. It's not the kind of thing where you have a flare-up of it and then things are better. It's constantly and chronically a condition where when someone is exposed to gluten and they eat it, there is direct GI tract damage. Now, if you look at this picture on the left side, this is a cross-section of the small intestine, the surface of the small intestine, and all of us have these villi, and you can see it increases. What it does is it essentially increases the surface area of the small intestine. That's where all of our nutrients are absorbed into the bloodstream. A lot of good things are happening on these villi. And then in the picture on the right, look at how they're just, completely damaged, and very small surface area then is left for nutrient absorption. And so this is really the issue, is that the GI tract is physically damaged through an immune response from the gluten presence. And the problem is that malabsorption of very, very, all the important nutrients that we need from the small intestine. It's estimated that 1 to 1.5% of people worldwide have celiac disease. What are the symptoms? Just as you would imagine: diarrhea, steatorrhea, which is fat in the stool, weight loss, mild, non-specific GI symptoms, bloating, belly aches, and such. Dermatitis herpetiformis, which is a very specific type of skin rash that people with celiac disease have. But what's really important about celiac disease, and for everybody to understand, it's not so much, okay, this person with celiac disease gets some gluten in their diet and they're going to have some diarrhea. It's what the problem is that direct damage to the intestine then is related to some nutrition problems. In children, delayed puberty, generalized fatigue, iron deficiency anemia, ulcers of the mouth and other dental problems, low bone mineral density and osteoporosis. Malnutrition is of great concern. And because of all of this, you can imagine with such a poor ability to absorb nutrients, autoimmune disease is related. Many people with celiac disease also get diabetes. And there's an increased risk for cancer with celiac disease. So serious business. What's the treatment? Strict gluten-free diet for a lifetime. Because of that damage that the gluten causes directly to the GI tract. That's the only way to promote the healing. And even the smallest amount of gluten, little specks and particle, can make a difference. That's why it's so hard to serve gluten-free foods, particularly in areas where, maybe you're baking and there's flour dust around. If there's other things going on in a kitchen, that cross contact can really be a problem. That's why we also have segregated equipment. Sharing a toaster or a frying pan or even a spatula or tongs is really a particular problem for celiac disease. And of course for other allergies, particularly if people have anaphylactics risk. Okay, this is really interesting. I came across a paper that researchers from Finland and the UK did, where they recently reviewed all of the major literature on celiac disease in the older adults. And the researchers found that 25% of all celiac disease diagnoses are now made in persons age 60 or above. And that, I think, plays out for many of us who work in senior living. We're seeing more and more diagnoses come through the door with a request for a gluten-free diet. They're also saying that approximately 60% of cases in older adults remain undetected, and that's due to the vague or non-classical symptoms obscuring the diagnosis. Now, another factor complicating the diagnosis in later life is that older celiac disease patients are more likely to test negative on the celiac disease blood test and have lower levels of the tissue transglutaminase antibodies. And what they do is, if someone has the glutaminase antibodies in the blood, they go and they follow up and they do a biopsy of the small intestine. And what they're saying is that both of those tests are falsely negative. They don't find it in the tissue or in the blood, even though they have celiac disease. So because of this, physicians should not immediately rule out a possible diagnosis of celiac disease in older adults based on the negative blood test alone, if there's enough other compelling signs and symptoms of the disease. Now, some question whether it's really useful or meaningful to look at celiac disease in the older adult population, especially when the symptoms are mild. However, and they're worried about this because, right, once we restrict an older person's diet, their risk for malnutrition skyrockets. And so is it really a good idea to try to get to the bottom of someone over, an older adult having celiac disease. And what they're saying that it is worthwhile because the currently available evidence suggests that a significant improvement in quality of life on a strict gluten-free diet is worth it. And that notably, this improvement in quality of life has been demonstrated even in seemingly asymptomatic elderly patients. And so screening is recommended for older adults. So I just think that paper is very interesting because I know in my practice, I'm hearing a lot about increased need for gluten-free diets with older adults. Okay. Let's look at what the FDA has to say about this. Congress passed the Food Allergen Labeling Consumer Protection Act in 2004, otherwise known as FALCPA, and this law identified 8 foods as major food allergens, and most of us are very familiar with these: milk, eggs, fish, crustacean shellfish, tree nuts, peanuts, wheat, and soybeans. And at that time, the 8 major allergens accounted for 90% of food allergies and serious allergic reactions in the US. In 2021, the Food Allergy Safety Treatment Education and Research FASTER Act was signed into law, declaring sesame as the 9th major food allergen recognized by the United States. And this change went into effect January 1st, 2023, this year. So now we have sesame to add to the list. So this 2004 Act, Food Allergen Labeling and Consumer Protection Act, FALCPA, and the Food Allergen Safety Treatment Education Research, FASTER Act, that's where our food labeling requirements reside. So some interesting points about that is thresholds have not been established. It's not like you can get away with so many parts per million being present in the food. 0 threshold, which is good. It applies to all commercially packaged foods, everything we see on the grocery store shelves, for example. It also extends to retail and food service establishments that package, label, and offer products to eat. Think about your rotisserie chicken. That's going to be well labeled because it was packaged and prepared ahead of time. Now, for foods prepared at point of service, they don't have to have the labeling. So if you go into a deli and order a sandwich and they wrap it in a piece of paper and hand it to you, that's not necessarily required. Now, there's also the allergen requirement on labels. The law requires that food labels identify the food source of all major food allergens used to make that food. So, for example, they can include the common name as the ingredient. Buttermilk. If buttermilk's in the product and they say buttermilk or milk, then they're covered. Another way that they can identify it is to name the food source in parentheses following the ingredient name. For example, lecithin, soy, and we see this on labels all the time, don't we? Flour, wheat. Or in a contains statement after the list of ingredients. Example, contains wheat, milk, and soy. They have to specify whether, the type of tree nut, the species of fish, or the type of shellfish used. And let me give you an example of that. So here, oh wait, I want to show you the advisory statement first. The advisory statement is not required by law, but we see these all the time. And they can be used to address unavoidable cross-contact. So in this example, oh, what is this? I can't remember. Oh, this is a brownie mix. So it says contains wheat and walnut, and it specified the nuts, the tree nut. It didn't just say tree nuts, it's walnut, and may contain egg, milk, and soy ingredients. Now, it shouldn't be used as a substitute for adhering to good manufacturing practice. For example, the FDA, expects that manufacturers are going to clean their equipment between hands and make all reasonable attempts to segregate foods so we don't have, minimize the amount of cross contact. They must be truthful and not misleading in their labeling. And here's an example of a breakfast bar. And I thought this was very interesting that, they just threw the kitchen sink at it, produced in a facility that processes wheat, peanuts, tree nuts, eggs, soy, and dairy. And you can see where even if folks like this made an effort to avoid cross contact, this is actually a small company. That's why I use this label. And they make all kinds of breakfast bars. And these are the kind of ingredients that are in breakfast bars. So interesting how the labeling. And the other thing is that folks can't have a little bit of leeway in how they express their labeling. Look at this. On the left, this is a can of tuna from Whole Foods, and they did say albacore tuna right in the ingredient list. That would have met the requirement, but they also made a contains statement. Contains fish. They had to say the species, tuna, ingredients. And then over here, Bumblebee did it a little bit separately. They said tuna in the ingredient statement, but look at this, contains tuna and soy. And you're like, wait, what? Soy in a can of tuna? Well, yeah, because it's water, vegetable broth, and sea salt. So keep this in mind when we talk about, how to implement a food allergy program in a healthcare setting. Product specification is going to be really important, and understanding what's in our foods is going to be really important. And that's what we're going to do next. We're going to talk about that. But first, let's do another poll. I'm wondering where everybody's at. We've got almost half of you from hospitals and other settings. Do you have a formal food allergy policy? How about if we launch the poll, Jenny?
Thank you, Maggie. All right, the poll is launched and open, folks. Go ahead and put in your response. So your options are yes, it is basic, or yes, it is, and it is comprehensive, or finally, no, you do not have a formal food allergy policy. So I will go ahead and check out that poll and see where we are. Okay, so we have right now 56% of our respondents, yes, it is basic. 24% yes, and it is comprehensive, but we still have about 21% that say no.
Okay, good, really helpful. Thanks, and thanks to those of you who voted, because it just helps in this next section. When I go through this, I want to talk about how to accommodate allergies and intolerances, and I thought we needed to contextualize this first before we get into some of these best practices, because we've got a pretty vast range of types of healthcare food service systems and situations participating today. So let's go through some of the things that I think we need to think about before we even talk about best practices. What's your average length of stay? If you're a hospital and your average length of stay is 5 days, the amount of foods that you have to offer and have available that are that work for a person with life-threatening allergies is a lot different than perhaps a senior living community that is literally serving someone food for the rest of their lives. So we have to really understand what the context is that we're talking about. What can your system and facilities accommodate? Do you have a separate kitchen that you can use to create an allergen diet and menu? Do you have a countertop that you can use? Do you not even have that? What about your transport systems? And what about your electronic health record versus paper system, et cetera? And the reason why I bring this up is not so much to overwhelm you, but for many of us on the call, you're going to be asked to be involved in this for your systems and your organization, and you have to be able to report back to folks that you're reporting to that we need to have an understanding of what we can accommodate. And related to that, of course, is what's your team's skill set? Are we going to create a system that is set to fail because we have such high turnover in our kitchen, and we're just trying to teach people how to get food out? To add another layer of complexity to this, is that going to work? So we really need to understand what our team's skill set is, and who is our team. Is it you, the dietitian, and maybe one other person on a clinical nursing, or do you have the full force of a 700-bed teaching hospital behind you? What are your local requirements? I'm in Illinois. In the state of Illinois, restaurants are required to provide allergen education and have an allergen program in their kitchens. Now, not that we in healthcare have to follow the restaurant requirements, but that's the expectation of your consumers. So be aware of that. And also, very importantly, what does your organization legal or regulatory team say? And there's a lot of liability related to this, a lot of risk. These are life-threatening situations. So we want to make sure that we understand what the constraints are that we're working with, and that we loop these folks in so that we get their perspective as we develop our programs and plans. So I broke it down into 4 categories. These are the categories of things that I think we all need to think about when planning on how to deal with allergies and food intolerances in a healthcare food service system. 1, admissions and diet orders. 2, menus, recipes, and ingredients. 3, what are we going to do about segregating allergens? And 4, the almighty communication. All right, let's start with the admissions and diet order process. We need to have an admissions process. First and foremost, you're going to need some kind of a tool. We have to identify folks as they're coming through our door that they have some type of an allergen or intolerance. And most importantly, we need to be able to identify life-threatening food allergies. So a lot of times these are part of the screening entrance tool. You ask folks, do you have any allergies? But it would be also very helpful to have some type of an admission script. So somebody says, yeah, I'm allergic to wheat. Well, wouldn't you like to know if that person has been diagnosed with celiac disease versus they've decided for themselves? Remember our early statistics about, folks self-reporting. We'd like to know things like, do you have celiac disease? Has it been diagnosed by a physician? Do you have a life threat? Is your food allergy life-threatening? Have you ever had to use an EpiPen? Do you have an EpiPen? Et cetera, et cetera. Have you ever been admitted to the hospital because of this allergen? We need to get some type of context because it was such a broad range of, it's a big umbrella we're under right now when we talk about food allergies and food intolerances. And then is there a way, once we've identified this, is there a way to keep a longitudinal documentation, meaning is that food allergy going to follow that individual through our entire system and through their entire stay, and even when they come back to our systems? Hospitals is one way to look at it. Long-term care and senior living is another way to look at it as well. All right, from there, we need to make sure that we have some type of official diet order. So we have probably in most of our settings, we have predetermined diet orders, predefined diet orders. Food allergies should be part of that as well. And then that food allergy needs to be transcribed to dining services, just as, now it's already been part of the diet order system. And then that food allergy once that order goes through, needs to be linked to a specific call to action. What's going to happen in the kitchen when they get that order? What's going to happen in the clinical areas once they get that order for the food allergy? And all of that has to be mapped out in policies and processes. From there, we look at the dietary software records. What's happening in the kitchen? We've got to identify separately life-threatening food allergies. I would also suggest we identify separately celiac disease versus wheat intolerance. So we need to have a list of the food allergens that you are capable of dealing with. And we need to know that when a food allergy is ordered, a diet order for avoiding a food allergy is ordered, and you'll have to work out what that language looks like. Do you offer a gluten-free menu, or do you have a gluten-friendly menu? How are you going to define that? What can you do based on your capabilities? But once that happens, that's going to trigger a dietitian consultation. So the diet, again, we had an admission kind of evaluation, but once it gets to the kitchen, the dietitian needs to have some type of a involvement through a consultation. So the dietitian completes a second screen and confirms the activation of the dining plan. And that's either he or she themselves, the dietitian who does the clinical screen does it, or they hand it off to the dietitian in the food service who does it. But we need to make sure that we follow through and we have a process and checks and balances within that. And then on the resident or patient side of things, we have to identify that patient as having a life-threatening food allergy or having celiac disease or food intolerance within HIPAA standards. Back in the day, we used to get a big piece of paper, put it on the door, put it above their heads in the bed, write it all over everything, put it on a chart on the wall. We can't, of course, do that anymore, and rightfully so. So we have to find ways to do that. Color coding helps. Sometimes a red band with their names. Some people use red labeling on a red placemats. If they use trays, little red napkin, there's ways to color code it. But everybody needs to understand what that color coding means. And also the written plans of care needs to have some type of visual alert for folks that this person has allergies. You also need some type of a plan for specific procedures for the EpiPen. And what to do if there is a problem. Do you have the right dose for that person? Is it available? Do they bring their own? Do you supply it? How does all that work? And are there risks for inhalation reactions? Do we need to be worrying about the entire clinical environment? Does that person need to have their own room, et cetera, et cetera? You can see there's lots of things that we have to think about. So just to kind of summarize this section, admissions and diet orders, our best practices include having that gatekeeper from day one. As soon as that person comes into our communities or hospitals, that we need to have somebody who's going to help identify that food allergy or intolerance. And then that would trigger all kinds of alerts so that the process has been established for dealing with that life-threatening allergy or the food intolerance or the non-life-threatening allergy. So communication is going to be key. There's got to be a way where we have easy communication for that longitudinal flow of the person's needs being met, the diet order. And we need some type of oversight, both on the clinical side and in the food service area. Dietitians are great for that as well. And it takes vigilance. There's so many opportunities for things to fall through the cracks just to get the admissions and diet orders right, that we need to be very vigilant about it. Electronic health records, and certainly, and we'll talk about this in a little bit, food service menu systems are really vital for being able to manage allergies in a healthcare setting. All right, let's talk about that. Let's talk about menus, recipes, and ingredients. Hold on a second. I think I missed a page. Okay, no, I'm good. Okay, menus, recipes, and ingredients. How do we do this? Well, like I said earlier, some hospitals, again, your average length of stay is 5 days, 7 days tops. Special allergen menu is probably the way to go. You have a very specific menu that has very specific foods on it. It's prepared in a very specific location, segregated location. It's delivered in a special way. Everybody knows about it. Boom. 7 days later, the person leaves and everything's fine. The problem is, what about folks who are with us for years? Another way to look at it is perhaps a menu matrix that lists all the menu items across a spreadsheet with the allergens identified. A lot more moving parts, a lot more to keep track of, but some people do this. They say to the patient, these are our foods that we know have these particular ingredients in it, so you can track your allergen. Now, another way to do it, this would work, I think, in independent living is probably the only place this would work, but a supported self-selected menu where we can say to someone, we can't have a gluten-free kitchen, but we can provide these prepackaged gluten-free foods along with these simple, fruits and vegetables and rice and such that we will take care in preparing, and we will help you. We will support you as you make self-selections from the menu of what you'd like to eat. And there's probably many varieties of this approach, but that's one of them, is to say, okay, we're going to help you manage this yourself. Through all of these, though, menus or recipe substitutions have to be checked with the dietitian before supplying an item to a patient or a resident with a food allergy intolerance. So we need, gate points where we have to double check and check anytime there's any kind of a change through this system. And then we have to be very mindful of choice. Are we, sometimes to boil think about a menu that doesn't include those 9 ingredients that we listed as the top allergens. That's kind of a boring menu. You can get away with it probably for 5 days, but you're not going to get away with it necessarily for someone who is living with you for years. And so we have to figure out how we're going to offer choice and individualize things and customize them for folks with these types of allergies. All right, what do we do about the recipes now? And basically, in the menus and the recipes, the trick with that is we want to follow the allergen. And that starts with standardized recipes. There's just no way to do any of this without standardized recipes. And it's just one more reason why we should all be using standardized recipes if we're not already. And the way we do that is your recipe, of course, calls for an ingredient. Well, we need to have specific product specifications for that ingredient. Think about that tuna that we talked about in that can of the tuna. So if we look over here, here's an example of a product specification where, this is for school lunch, but it's very specifically even has a section for prohibited ingredients. So you could develop some language around some of your product specs that talk about if it's tuna, it can't have soy in it. That would be a very specific way of doing it. Another simpler way, here's an example. We've got our tuna here. Again, this is not considered, this is used for military actually, that here's tuna and they have sodium limits, and then they talk about an acceptable food product is chicken of the sea. So you could see how you could develop some allergy language around these product specifications, which could be really helpful. And so then what happens is your allergens are tagged in your ingredients when you're creating your recipes. And if you can tag your allergens with the ingredients, so that tuna, let's say we said that tuna, well, it has fish, it has tuna in it. It's tagged with that item. And then so when the ingredients added to the recipes, the allergens follow. So now the tuna salad sandwich is tagged for allergens. And when that tuna salad sandwich is put on the menu, it's tagged as well. And the allergens follow that way. But the problem is that any ingredient change you make changes with the menu. So here's some best practices. You have to have a trusted vendor relationship. You need to know where your food is coming from, and you need to hopefully have someone who's going to be willing to have a contract with you where they're not going to make substitutions without letting you know, which any of us who work, in food purchasing, et cetera, know, there's not a lot the vendor can do about it if a item isn't available. We have to be really careful about being able to identify and have a process for figuring out all these changes that happen to the ingredients that we serve, which is why we're working with a moving target, and we have to figure out processes to minimize that just craziness of tracking all these ingredients. And that's why a simplified order guide is really the way to go, particularly in hospitals, because you don't have to have as many food items offered. In senior living, we serve, a 3-week, 5-week cycle menu with 4 offerings each meal, et cetera, et cetera. Where in the hospital, it's a little simpler. We can have an order guide, and we can focus in all settings, focus more on the whole foods and less multi-ingredient packaged food products. All right, the next section is what are we going to do about segregation? And I'm going to very quickly go through this because it's a little deep in terms of the specifics, but I want to give you a flavor for what folks are doing. So they're identifying how they're going to store their food, how they're going to have their areas cleaned and utensils available and clean. Are they going to use PPE? And where are they going to keep everything to prepare these allergen-friendly meals? And then how are they going to identify that when they go to make the food, double check that the allergen is certainly not present in that food. They have to prepare the food in isolation, have a process for, when you're taking things out of, decanting it from the original container, that we don't have cross contact. Is there someone who's going to accurately prepare and plate that food, and someone's going to check? And then how are we going to store that, cover and store it until it's time to serve it? Once it's served, we need to make sure that it's checked to be correct and it's transported in a manner that minimizes contact. And then we have to identify that patient or resident to ensure that they're the correct patient and that they're getting that meal. And then what are we going to do if the person's not in their room or their bed? What are we going to do about substitutions, snacks, and feeding? So lots to think about in terms of segregation. But these are the best practices. Have policies and standards and specifics for food storage. Keep a separate space for safe food preparation. Make sure you have segregated equipment, a process for food delivery that is segregated and covered, and that there are written plans for this so everyone understands. And then lastly, we've got communication. A knowledgeable team saves lives. It's that simple. It needs to be included in the orientation for everyone who comes on your team, but it has to be tailored to the job function. The person who's preparing the food needs more training, perhaps, than the person who, it maybe is simply in dishwashing in your kitchens. And that applies to your clinical settings as well, tailoring the training to who needs what. Include the why. This is important. It's life-threatening. We all have a very important role in this. Know your regulatory requirements for training if you have any in your state, and consider commercial programs. Because of the restaurant requirement, there's some really nice commercial programs out there that could be very helpful. And then you need an emergency plan. How are you going to identify symptoms of an allergic reaction if you have a problem? Know what to do to provide help. Know about follow-up so that it doesn't happen again, kind of as they say, a post-mortem of what happened. And here's a really good example of, and this is free, by the way. This came from FAIR, and I just took a screenshot of their training, but they have this free online, and it's a 15-minute training on what is anaphylaxis, how to recognize it, what to do if someone's having a reaction, and how to safely use and maintain the EPENs. So I thought that was really interesting that that's out there. And so even for your own information, you might be interested in having this type of training. In terms of communication, a policy needs to be in place to manage and identify the documentation and communication of food allergies, meaning we need to have a policy that everybody understands what's going on and we're communicating with each other about this. And then we need to audit regularly to make sure that the processes are conducted regularly and after an incident, especially after an incident, because if there is an incident, this after allergy incident is what's going to help you identify the problems that you have with your systems. And it's also going to help build trust because that's how people are going to feel like you've got this under control, and you have a sense of wanting to be successful and wanting to take care of them with their food allergy. And so I'm going to wrap this up with these last best practices for communication. And that is, of course, we need to train. We need to train everybody who has anything to do with food, from your food service folks to any type of activity or therapies that may involve food. All your clinical people need to understand, and your administrative people need to understand too, because this all falls under patient safety. You need to have an emergency plan. What's going to happen now in the hospital setting? A lot of folks, they defer that to the clinical team or even the emergency room, because the emergency room is very well set up for these types of emergencies. But what's the plan in senior living and other smaller organizations? What's the plan? Who's going to call for help? Who do you call, etc.? Communication amongst your teams is so important. Within your team is very important. It's the only way this is going to work. And monitor yourselves so that you can build trust among those people that you're caring for, so they know that you really can take care of the situation. Manage expectations. Again, a teaching hospital, any hospital should be able to handle an allergen, period. In other settings, you may not be able to do it. You may not be able to offer a gluten-free diet for someone with celiac disease because you're just not set up for it. So it depends on what the expectations are of the person you're serving, and that you've got trust there so that you can help them be successful and keep them safe. All right, I've got a few calls to action before we take some questions. And that is, these are your what I recommend that you look at next, if especially for those of you, the 21% of you who do not have a plan. One, explore and define your food allergy policy. You're going to have to put it in writing and figure out what it is that you can work in the context of your capabilities. Track your process from allergy identification through meal consumption. That's a really good way to make sure you've covered all your bases and have all your stops and processes in place. Strengthen your recipe, menus, and procurement standards. Try to put some control in these ingredients that are coming into your kitchen. Otherwise, it's almost impossible to keep up with. And again, we got 9 allergens we have to keep track of. So you're going to have look at your procurement standards and how that all, again, follow the allergen. And then lastly, establish strong communication for successful implementation. That's very important, both through the process as well as if, unfortunately, you have incidents. Don't shy away from that. Dig into that. Figure out what went wrong. Make sure everybody understands, and do your best to avoid any additional problems in the future. All right, lots of material I covered. Jenny, I'm wondering if we have any questions, and we can open it up for that now.
Fabulous. Thank you so much for joining us today, Maggie. We will go ahead and take one question. Let's see. Our first question comes from Mary, and Mary asks, can there be a gluten intolerance rather than an actual celiac diagnosis?
Yes, and there also can be wheat allergies. So gluten intolerant can be someone who says, I don't have celiac disease. They may or may not have been tested for it, but I do not tolerate gluten. I get a rash, I get a bellyache, I get bloated, but I don't have celiac disease. Absolutely. And those are the folks that are a little easier to deal with because you don't have that terrible autoimmune damage to the small intestine that you do with celiac disease.
Thank you so much. Thank you. So I do appreciate your time today, Maggie. We are almost at time. So I did want to say thank you to everyone for joining us today. You will be receiving an email in the coming days with links to the slides presented, as well as the continuing education certificates. Please do plan to stay connected with General Mills by visiting our website and social media handles to access more resources. Additionally, we do hope to see you in early August at the AHF conference in Orlando. For those of you that can make it, please come visit our booth, 505 and 507. Additionally, please make sure to visit generalmillscf.com for information on rebates, helpful marketing tools, videos, and new item launches. We also offer a gluten-free product guide there. This concludes today's program. You may now disconnect. Thank you so much for joining us today.
Bye, everybody.
Thank you.